Hi, my name is Ligio Illy-Perenville. I'm an assistant professor at Temple University, and today I'm going to talk about lung physiology, the basics number 5. So what we're really going to review today is the mechanics of breathing, and specifically the physical and elastic properties of the lung. We're going to kind of look into compliance and understand hysteria. Really, it's hysteriosis, but I call it hysteria because it is an interesting way of looking at how inspiration and expiration are different because of how the lungs compliance changes. As always, I like to start with a clinical vignette. So we have a 42-year-old female with a past medical history of progressive fibrosing ILD secondary to HP, asthma, allergic rhinitis, prior tobacco use, OSA on CPAP with chronic nocturnal oxygen, prior PE, GERD, who presented by EMS for 1 week history of cough, sputum production, fevers, and worsening dyspnea. In the ED, her heart rate's 115, her blood pressure is elevated, her respiratory rate is also elevated at 37, and she's using accessory muscles. She's sat 65% on room air and was 88% when she was transitioned to a non-rebreather. So, how do we inspire? How do we take a breath in? Well, there's a really good paper that kind of described all the mechanics of the lung back in 1950 by Otis et al. From the University of Rochester, where they kind of broke it down step by step. I'm going to try to go through that with less math. So, where does inspiration really come from? The diaphragm. That's really our initial muscle for inspiration. It's innervated by cervical nerves 3, 4, and 5. What it does is when it contracts, it flattens out, pushes the abdominal contents down, and creates negative pressure that allows a passive flow of air in. Generally, you really only need a negative pressure about 1 centimeter of water with normal tidal breathing. But under exertion and activity, you can use as much as negative 10 centimeters of water. There are some inspiratory skeletal muscles. These are generally used when you use accessory muscles of breathing. There's also a pump system with inspiration, specifically the bucket handles, which are our ribs, and the pump handle, which is your sternum. These are affected by the external intercostals and the sternomastoid muscle. Specifically, the external intercostals work on the ribs, and the sternomastoids work on, well, your sternum. So what happens on inspiration to the pressure of the lungs? I keep talking about this change in pressure and how that's how you breathe. Well, there are two pressures you have to keep in mind. There's the pressure of the pleural cavity, and then the pressure of the alveoli itself. Now, at the end of expiration, your intrapleural pressure is negative, usually about minus 5 centimeters of water. However, with contraction of the diaphragm, it becomes more negative. And this overcomes the elastic recoil of the lung, which allows air to passively flow in. What this looks like is something like this. So here's your intrapleural pressure, about a -5. Let's say you take a breath that makes about 3 centimeters of water more negative, which brings it down to -8. That allows a volume of air to come in, right? But notice the alveolar pressure. The alveolar pressure starts at 0, goes negative as you go negative, but then equalizes back out to 0. And that's the end of inspiration. Okay. And that's generally how inspiration works, right? You create this negative pressure. The alveolar pressure is initially negative, but then goes back to being 0. And that's what essentially stops that flow of air. Well, how do we expire then? Well, inspiration is a active process. You need your diaphragm to contract, or if you need it, you can use your accessory muscles. Expiration is usually a passive process, especially under resting settings, right? The elastic recoil of the lungs really just allow the lungs to contract and force air out. The abdominal tone of the abdominal muscles also help because this actually allows natural relaxation of the diaphragm. Now, it can be active under exercise or voluntary hyperventilation. You have internal intercostal muscles that contract, and that actually causes air to be forced out. And then you have accessory muscles that relax. And then people can use their abdominal muscles to really breathe. And generally, you'll see the abdominal muscle contractions more in children who may not have the other strong accessory muscles that we have. What happens to pleural cavity pressures and alveolar pressures? Well, intrapleural pressure becomes less negative, right? Opposite of what happens on inspiration. And then it's this difference in pressure with combined pressure from the elastic recoil of the lung that increases that alveolar pressure and then pushes the air out. And what it looks like is something like this. Here's your intrapleural pressure going back more in the positive direction. Your alveolar pressure starts going more in the positive direction, and then air starts coming out. Now, eventually the intrapleural pressure hits back to where it was, right, at the end of expiration, and your alveolar pressure goes back down to zero, and you exhale all the air. Now, to understand what's happening and why the compliance of the lungs is so important, you first need to understand the general pressure volume relationship of an ideal gas, right? And this is really kind of best described by Boyle's law. Now, Boyle's law states that for a given pressure and volume, there is a kind of inverse relationship between that pressure and volume, right? And this is assuming a standard temperature, right? There's no fluctuations in temperature. And that when you compare volume related to 1 over pressure, that there's a linear relationship between the two. However, in the lungs, this flow and change in pressure and volume depends on whether it's on the inspiratory, the inflation loop, or the deflation loop of the lungs. Because instead of having that kind of constant change per pressure per volume, you have a inspiratory pressure volume curve and an expiratory pressure volume curve. And this is even seen in tidal breathing, where your inspiratory pressure volume curve or limb is different from your expiratory pressure volume limb. Now, this difference is known as hysteriosis. Now, let's talk about it a little bit more. We know that compliance of a lung is really the slope of the pressure volume curve. So compliance is equal to the change in volume per change in pressure. Now, normal ranges for the lungs is very compliant. So if you're looking at intraalveolar pressure, the lungs remove roughly 220 mLs of air per centimeter of CO2, per centimeter of H2O, I'm sorry. So that means very quickly, you'll move a lot of air with minimal pressure changes. If you include the chest wall as well, it's about 130 mLs per centimeter of water pressure change. However, extremes, you can notice that the compliance is less. So when you're near the end of your full volume, that's your residual volume, you can see you actually need a lot more pressure before you can get a volume change. The same thing happens when you get near total lung capacity, right? You need a lot more pressure to get a significant volume change. And that's why tidal breathing exists in this kind of middle area, where you actually don't need that much pressure to get a huge volume change and vice versa. When you look at it in relation to interpleural pressures, it moves roughly about 200 mLs per centimeter of H2O. And the lung plus chest wall moves about 100 centimeters of 100 mLs per centimeter of H2O, right? But the relationship still holds at the extremes. So going back to this, the difference between the two can be seen also on your inspiratory loop and how your expiratory loop works on your intrapleural pressures. Right? You can see that in the inspiratory loop, it's a pretty constant phenomenon, right? But because expiration tends to be passive, there is this kind of inflection point in how quickly the pressure changes, right? But if you look, the volume change isn't that significantly different. And this has to do with the elastic recoils and properties of the lungs. So let's talk about hysteriosis, right? Hysteriosis has to do with recruitment and de-recruitment of the lung. So collapsed alveoli require energy. Now, you don't need the same amount of energy when they close. You need it when you need to open them, right? This also alveolar surface tension. It's decreased when collapsed. and increase when fully expanded. There's also an impact of stress relaxation, which is a loss of energy in the lung parenchyma when stretched. It's not a true stretch. If you get into the physics of it, it's called an imperfect stretch. But for the purposes of this, just remember that there's a loss of energy in the lung parenchyma when it gets stretched out. Now, depending on where you measure it, some of the gas may be absorbed by the lung itself, which can affect how you can measure the pressure and volume. But the most significant components are actually the recruitment and derecruitment and the alveolar surface tension. And as the lung expands, right, there's a point where it's easier to expand. And then you reach the extreme. So it's a balloon that's been fully expanded. The same thing happens when it starts to deflate. As it deflates, there's a point where it'll deflate a lot faster. Well, a lot more easily, not necessarily faster than other areas. And then it'll reach the end where it can't deflate anymore. And getting out that last bit of air may be a difficult maneuver. Now, this was actually kind of best described in a static lung in a paper from 1971, though the original studies were done in the 20s. And what they did is they took a cat lung and they inflated it with air, right? And they noticed that hysteriosis, right? And you can see it here, right? So here's your inspiratory loop and here's your expiratory loop. But then they actually inflated it with saline and they noticed that that loop, that difference, that hysteriosis disappeared. Well, it turned out that surfactant is one of the big reasons why we have this hysteriosis. And that's what allows this kind of difference in alveolar recruitment and derecruitment and alveolar surface tension, which is all kind of defined by surfactant. Now, another thing to know is that compliance of a lung also depends on its size, right? So, for instance, mouse lungs are 1.2 milliliters. They are quite small, which means that if you try to move a lot of air in them, they're not going to move very quickly because the pressures are going to be pretty high. Human lungs are about 6,000 mLs, depending on your height and gender. Blue whale lungs are 5 million mLs. So you can see that there's a huge difference, and the amount of air they can move per centimeter of water can change quickly based on their size. Now, there's a component called specific compliance, which tries to standardize this between all the different species. And really what that looks for is change in compliance per specific unit of lung, which tends to be per over FRC. Now, I will tell you that in a general sense, specific compliance isn't really helpful in most cases when looking at people, because you're really not trying to compare too many people with very varying sizes in lungs. However, and it can be important to understand how pressure volume loops work with different types of pathological states. For instance, we know that emphysema leads to increased compliance, which means that you get a larger change in volume per unit pressure, right? Whereas fibrosis has less compliant lungs. So you actually get less movement of air, less volume of air with increasing pressure as well. Now, to put it into a little bit more definitive terminology, there are actually there's 4 types of compliance that the lungs can do. Specific compliance, we've already talked about. It really just helps normalize the compliance by lung volume. Like I said, it's really not useful unless you're comparing a child with an adult or a blue whale. I don't know if we'd ever compare blue whale lungs to our lungs, but you know. Respiratory compliance is one of the factors we use. It's the change in lung volume per unit change in transmural pressure. Normal is about 100 mLs per centimeter of water. Transmural pressure is that pressure that the capillaries in the alveoli can feel. Static pressure is the change in volume per unit change in pressure in the absence of flow. This is the pressure that really looked at with the cat lungs, right? You're just instilling saline into it and you're looking for the change in pressure. There's no increase in flow. Dynamic compliance is the one we really use most of the time. It's actually the change in volume divided by change in pressure measured at normal breathing between two areas of zero flow, right? And that's the one we use generally when we assess a patient. However, a relationship between dynamic compliance and static compliance can actually give us a lot of information about airways disease and things like that. So, what are the things that increase compliance? Well, in the lung, there's surfactant, emphysema, aging. Aging works in a similar process to emphysema. You actually lose a lot of your elastic recoil tissue over time. Volume does help, but remember, it's only really at that FRC zone, right? Because once you get to high volumes, you actually lose compliance. And of course, posture, right? Posture is actually one of the biggest things that help compliance. You can see that people will adjust their posture when they're dyspneic to help move air better, especially if they feel short of breath. On the chest wall side, you have cachexia, so loss of chest wall muscle, and strength means that the lungs can actually move more regularly. Open chest makes sense. You took away the chest wall from the picture, really. The lungs are open to the air and they're able to move pretty freely. Connective tissue disease, right? So specifically Ehlers-Danlos and Marfan's, you can see this. They lose their elastic recoil, right? Their elastase and elastic fibers are not properly aligning and not properly elastic, I guess. And so they can have increased lung compliance. And rib resections. So rib resections take away some of the chest wall's ability to move out or move in, depending on the type of rib resections. You lose the musculature around it, and that can actually affect your lung compliance and increase it. Decreased lung compliance tends to be pathological states. So pulmonary fibrosis, pulmonary edema, loss of surfactant, specifically ARDS, and more rarely surfactant deficiency. Decrease functional lung volume. So think about resections. They can decrease your compliance, but actually improve how you breathe, especially in the lung volume reduction world. Pneumonia can decrease your compliance, atelectasis, alveolar derecruitment and overdistension. So we're really talking about those extremes on that loop again. Increased airway resistance, so asthma, COPD can decrease your lung compliance, mostly because it's harder to get the air out, right? So you can get air trapping, which can actually make your lung full and kind of stiff, even though the tissue itself may be compliant. Increased airflow, high respiratory rates can actually decrease your compliance. This also kind of fits with that high air trapping component. However, there's also kind of changes in how resistance occurs with increased airflow and increased pulmonary blood volume. So if your lungs are congested, heavy, full of blood from kind of congestive heart failure or something like that, they can actually become less compliant. Things that cause decreased chest wall compliance are structural abnormalities. So really, your kyphosis, your scoliosis, severe enough to kind of cause your lungs to be restricted. Spasms and seizures for obvious reasons. Obesity can be a relative sarcopenia with the increased weight, which can actually cause your chest wall compliance to come down. Abdominal compartment syndrome. The compartment syndromes are well known for decreasing chest compliance because they don't allow the musculature of the chest to behave normally. And prone position, right? If you think about it, you took the bucket handle out of the equation from the prone position. So going back to our patient, what factors can really affect her compliance? Well, fibrosis, right? She's got this progressive fibrosing ILD, pneumonia, right? I think it sounds like a pneumonia. She's got a cough, speed in production, worsening dyspnea. She has fever. She's got hypoxemia and hypoxia. So, kind of looks like pneumonia to me. Atelectasis. Yeah, she may have some component of atelectasis versus pneumonia. It would be hard to know. Increased airway resistance. She has asthma. Is this an asthma flare-up, right? Based on how fast she's breathing and things like that, is she just air trapping, and that's why she's so hypoxic? Increased airflow, right? Again, the high respiratory rate, right? So all of these things can really kind of explain some of her symptoms. and why her compliance is going to be lower, right? Her lung compliance is going to be pretty um, poor overall, and ventilating her might be quite difficult when you start. If you definitely have to put her on a ventilator, which, based on some of the values we're seeing, may be where she's headed. So, well, going back to our patient, right? Really, which compliance can really help them? Well, if you look at static compliance is a still lung with no flow, right? So that's not really going to be useful for someone like our patient. However, dynamic compliance is really useful in spontaneously breathing patients. And really, when you look at her dynamic compliance, she probably kind of fits this lower compliant curve where she's got a fibrotic like picture. Well, she does have fibrosis, but on top of that, other reasons why her lung compliance is poor. But remember that her compliance is also dependent on air resistance as well, right? And to understand how small airways disease in our patient with asthma may affect her compliance, you actually need to know what the static compliance is doing. Um, One of the factors of small airways disease and how it can affect the compliance is how quickly you can breathe. And this goes back to that air trapping and breath stacking that we talk about, right? People with small airways disease, as they start breathing faster, can lead to less compliance, right? They start stacking, they start not moving air well, their lungs become less compliant. And that's a consideration for our patient as well, on top of her interstitial lung disease. I do think, you know, especially given her history of pneumonia, she is at risk for having an asthma exacerbation on top of her ILD, and really trying to manage her um, so that she's in her best position to ventilate and oxygenate is something that you can do on the fly when you see her, but understanding these relationships between her dynamic compliance and all the factors going into it. Thank you very much, everybody.